Hello, everyone, and welcome. I'm your friend and host and the moderator of the session, Dr. Sayed Salman Ali. I'm the head of global education and innovation in ROOTT, Dental Implant System. Welcome, and it's amazing having you here. We are actually discussing something really innovative and really amazing today. It's one of the new products from ROOTT, and I would also like to invite Dr. Mustafa. I think he's probably running like 5 minutes late, but he'll join us soon. But before that, I would like to give you an overview about what we will be talking today. And this is about the roots ZBL-AHS protocol. So the root ZBL-AHS protocol is, as you know, that when you buy the root implants, you already have a complementary zero bone loss abutment. And this zero bone loss abutment is also your tie base. So it's a digital abutment and it's a digital final abutment which can be used to design your prosthesis directly. And what we have done is we have actually worked on this abutment digitally so that you can get the maximum out of it. So as you know, most of the companies or the competitors now, they're having anatomic healing solutions or anatomic abutments, and they're making it and they're selling it to you. So with Root, what we did is we actually leveraged the digital workflow, and we actually created something which is very easy to work with and 100% compatible with ZBL. So we have some evidence-based contamination protocol. We will also tell you how the ZBL-AHS protocol works in immediate implant solutions, especially for socket sealing techniques. And also this ZBL-AHS protocol, how you can develop emergence profile and manage your soft tissues. So I would just like to give you one of the most key slides that we have. This was the research which was done by Dr. Wadhwani. And as you can see on the left side, we have a completely new healing abutment, which is just removed from the box. And on the right side, you have this used, clean, and sterilized abutment. And the pink pigmentation that you see is actually the protein pigmentation, which is attached on top of the healing abutment. So most of the doctors, or I think the correct number is 92.6% of the doctors reuse the healing abutment. And ideally, a healing abutment is only to be used once, a single time, because of regulatory and the classification. So most of us, they use the healing abutment, reuse the healing abutment because of economic pressures. And also there is lots of limited clinical data available on this topic. And most of the companies, like big companies, don't even want to talk about this topic. So I'll just give you a electron microscopic structure picture of a healing abutment here. As you can see, these are epithelial cells and blood proteins. Once you remove a used healing abutment inside the patient and you study it under an electron microscope, you will see the remnants or the live cells, like dead cells of epithelium, keratinocytes, and the fibroblast attached on top of this healing abutment. So it's usually not seen with a naked eye, but when you use an electron microscope, you see all the remnants, all the blood proteins, and all the epithelial cells attached to this surface, and it's very difficult to clean. As you can see here, this is also one more picture, and on the right side where you can see my cursor, you see these cells are still attached. We can clean it, we can again sterilize it, but this is not the same surface which was there before. Now the surface topography and the geometry has been changed. So what are the cells when we have in the supraimplant complex is what we are dealing with is the fibroblasts, the keratinocytes. So fibroblastic cells, it's usually deep inside near the connection, and the keratinocytes make majority of your junctional epithelium and the sulcular epithelium. And the third and the most dangerous component in this sulcus is the microbiome. So we have fibroblastic cells, we have epithelium, and we have all possible bacteria inside the sulcus. And as we understand that the more fibroblastic cells, the more keratinocytes we have, the better the tissue quality will be, and the healthier the tissue will be, resisting peri-implantitis. The problem happens with the microbiome. If the microbiome is too high or the bacterial load is high, it will create perimucositis and eventually peri-implantitis. So this is also few published papers which exclusively talk about not to reuse the healing abutment. So we have few papers from Wadhwani, we have few papers from Nardi, and there are few articles on ethical consideration of this, whether to reuse the healing abutment or not. And last and the most important thing is also the manufacturer guidance. So every manufacturer, because healing abutment is classified as a type 2B device, it is exclusively mentioned that you should not reuse this. So this is one of the articles which states that the reuse of healing abutment according to the biological and professional training. So this was a survey which was done, and it found out that most of the doctors reuse the healing abutment because of the cost constraints. So the cost and the economics is actually a major issue when you're talking about reuse. Practicality, the third one is difficulty in availability. Maybe you want some specific heights or specific size of healing abutment which is not available. Last but not the least is the reuse itself. So again, second articles, which is more or less the same, most of the doctors think that it's not practical to reuse the healing abutment again and again. So this is just like one more idea that which of the segment mostly reuse the healing abutment. So most of the general practitioners and postgraduate students has the highest number of reuse of healing abutments, and it's just a segment classification. Then is it safe to reuse the healing abutment? So this is one of the articles which states that like there is lots of problems which you can encounter while reusing it. The key risk of reuse is whenever you reuse the healing abutment, you cannot decontaminate it 100%. You will always encounter some amount of residual organic materials, blood proteins, adhere to this, eventually leading to inflammation. Second, it increases the risk of peri-implantitis because it's not a uniform surface anymore. It has undergone changes. It's not smooth. Third is like most difficult is the prion transmission diseases. So there are some diseases which are actually used vector as prions, and it has very few amount of patients or very few amount of cases having this prion transfer diseases. It's like an autoimmune disease, and it can happen. So this is also a risk, like there is contamination risk or cross contamination of diseases which can happen, and the risk is one in 2,000 people. So some people say it's like a good amount of risk, some people say it's like negligible risk, but the risk is still there. Third, again, whenever you clean the healing abutments, it's not completely cleaned. There is always some remnants of biofilm and microorganisms even after autoclaving it. And the current treatment or the current sterilization method does not guarantee 100% of removal of the organic as well as the bacterial aggregates. So again, this was one more study which was done in US by the residents, and they found out that 21% of the healing abutments which were reused were more highlighted the risk of peri-implantitis, and eventually some of the cases were also suspected to have been failed because of the reuse of healing abutment. So the biological implications. So let's see, like this is how the reuse of healing abutment looks like healing abutment after autoclaving and re-sterilization. And as you can see, there are lots of debris, and there are some color changes, and there are also topographic changes. So the surface is not the same. The results, like what we found in histological findings, was the inflammatory response is 100% because it's not the same surface. It has some blood proteins, it has some adhered epithelial cells, and this will spike up the inflammation inside the patient in the peri-implant surface area. Then second one is there is always a risk of elevated cytokines. That means the inflammation is already increased, and this will prove to be a risk for the patient to be in the state of periimplantitis or perimucositis. Cellular infiltration was seen in higher numbers in reuse of healing abutment cases, and obviously it will affect a lot in vulnerable populations like diabetic, immunocompromised patients, or smokers. So this is just a picture of the staining which was done to identify proteins in the healing abutments. Different companies were selected, and this was done when the patient we remove the healing abutment, we clean it, we autoclave it, and then we stain it. So even after cleaning, autoclaving, this is what the result was. And some of the stains that you see, it's very heavy. Which is the most affected parts in terms of cleaning? So the highest amount of debris, you will always find it in the screw access hole, because this is very difficult area to reach out and clean it. The second was the body of the healing abutment itself, then the occlusal surface, and the last was the connection area or the screw thread design. So this is really, really important to consider. So there was some evidence that was standard decontamination protocol of just ultrasonic and autoclaving. You will always find at least some amount of debris. If it's not 100% that you have followed the protocol, most of the population found 31% of the contaminants in the reuse of healing abutment. The second was enhanced protocol, in which they use sodium hypochlorite to clean it, but still the debris were not gone. There was still a contamination of 2.4%. And the more optimal protocol was to use an air polisher to polish the healing abutment completely with the air polisher, but still there were some remnants, which was particulate remnants of 1.5% still exist even after this optimal protocol. So the conclusion is even aggressive decontamination protocols were not enough to achieve zero contamination levels in the reuse of healing abutments. Just a moment. I was actually waiting for Dr. Mustafa. He was actually having a surgery. He will join us pretty soon. I will just give you a gist about how it works. So perceived limitation is also there. Some of the doctors think there is no problem using it because they don't have the published data available in the market. Most, like 31.8% of the people, they understand there is some remnant organic matter, but which can be cleaned. Unless and until you stain it, you will not find it. Then 20% of the clinicians, what we did a survey, they think that after reusing the healing abutment, there are changes in the surface and the surface will become rough and corroded. Even because of repeated cycles of autoclaving, the surface does not remain the same, because the heat and the proteins, they actually react and it will corrode the surface, or there will be some corrosion, or the surface is not like a smooth surface in which this fibroblastic cells will come and attach. And last but not the least, there is always a 10% chance of cross-infection, because if it's not cleaned properly, you will have some amount of bacterial substrates, which can result into inflammation and eventually periimplantitis and more soft tissue complications. Also, let's dive into the global regulatory standards, what they say. So the first one is FDA. So according to FDA, it's a class 2 single-use device. So reprocessing is not, it will actually prevent the doctors or put the doctors at a legal risk of medical legal litigations. EU MDR, again, they also classify healing abutments as a single-use device. Third one is Saudi FDA. It's also one of the most reputed regulatory standards for the MENA region, and it's again classified as a type 2B device, which is again avoids the reuse of it. And CDC classification, again, cross-contamination is possible, and you're not supposed to reuse the healing abutment. This is just a summary of whatever I told you, why it's a risk. The problem is if there is any failures, and if the patient understands this, concept that if you reuse the doctor is not supposed to reuse the healing abutment, you are exposed to a medical legal litigation uh, which might affect your practice. So this is not a healthy thing to do. Also, this is an IFU from our company, ROOTT, which clearly states that the healing abutment is a single-use device and should not be reprocessed. Reprocessing could cause mechanical, chemical, and biological characteristics. Reuse could cause local or systemic infection. So, as I told you, like most of the time, we as clinicians, like me, including myself, we don't read the instruction for use manual. And if we don't use the instruction for use manual, we are supposed to have some amount of complication, or the learning curve time will increase. So this learning curve time, if it's increased, it might just end up into a complication that is uninvited. And we really, as clinicians, we don't want it. We don't want to have any unnecessary complications from the patient side or from the clinician or from the clinical side. So just to wrap this up, what can we do is we can always take a consent from the patient that if there is a medical, if there is economic issues, or if the patient is having economic pressures, we can tell the patient that, okay, you can sign this consent and we will reuse the healing abutment only by your permission. Most of the doctors don't even have the informed consent, and they still reuse the healing abutment inside the patient, which will expose them to a litigation risk. So this has been happening in the developed markets already. Like if you talk about certain markets in Europe, this is mandatory for them to take the consent of the patient, even if there is something specific that they want to implement. So if they want to reuse a certain component which is a part of the treatment, they need to sign a consent paper which states that we allow the doctor to use this in us during the treatment because of XYZ reasons. So this is really important. Second, as I told you, this on the right side, the A picture will give you a corroded surface of the reused healing abutment, and on the B side, you will see a new healing abutment which is placed inside the patient. So because of reusing the healing abutment multiple times, you have altered the topography. Sometimes even the biocompatibility of the surface is lost, and that's why you might have some issues. Maybe some of the patients might have some problems. Maybe they have a sinus tract, maybe you see mucositis, an inflamed area around the gingiva. And eventually, this is not really something that I, as an implant clinician, is willing to see inside my patient. We don't want to see any inflammation. We don't want to see any compromises in our patient. And this is how we don't want to, we want to do best for our patients actually. Again, as I told you, biological risk is too high. There is surface disintegration, and also there is contamination from the reuse. Medical legal risk is really high because it violates the regulatory, and it also violates the patient of the manufacturer's IFU. So this is really a concern which is coming up in the developed markets, in the developed countries, that the patient is actually litigating the clinician or the surgeon, so that and it's a problem because if there is an informed consent for the reuse, it's okay. But if there is no consent and still we use it and the patient finds out, then we are exposed to a medical legal risk. So always we try to single use it, but single use healing abutment is also a cost to the doctors, and to use it in all the patients like new, it's sometimes quite difficult even for the patients as well. So we at ROOTT, we have found out a solution for this, and this solution is actually this tissue sculpting system. So I was actually researching how to manage and manipulate the soft tissues around the implants, and I was able to find a process in which you can use this specific modality that we created at ROOTT to be 100% contamination free, no risk of reuse, and still you can achieve a very good emergence profile like natural teeth with this ZBL-AHS protocol. So we made it predictable, we made it duplicable in all prosthetic designs, and we made it compatible with the with our complementary ZBL abutment. So this was again a very nice article which was published by Professor Ronald Young. It said that whenever there is like each tooth, natural teeth has a proper emergence angle in which it comes out from the cement enamel junction. And this is the most healthy way to preserve the amount of tissue around the implants or around the natural teeth. So we worked on this as a reference, and we created something that is very important for you to achieve really healthy clinical profiles. So if we don't have a nice emergence profile, what will happen? So we will have food impaction or entrapment if we don't have a beautiful emergence profile. Second thing is, because of this food entrapment, there will be poor aesthetics, malodor. Because of lodgement of this food, there will be a high amount of bacteria, high load of bacterial substrates, which will leach into the peri-implant sulcus, and it will create peri-implantitis. You can have open contacts, and the worst issue is in the anterior to have black triangles and eventually aesthetic issues. So how can we do it? How can we achieve what we really want to achieve? So just a moment, I think Dr. Mustafa has arrived. So how can we achieve an ideal emergence profile? Or how can we achieve something which is aesthetically impeccable, aesthetically appealing, even for us and even for our patients? So we can actually stimulate the tissues around this peri-implant sulcus, and you can mold it into a proper, beautiful prosthetic contour. So this is where the ZBL-AHS protocol is. We have created something which is contamination-free, zero risk. You will have superior soft tissue outcomes, and it's completely compliant. And we have good evidence that you can achieve really excellent results with this. So let me present to you the ZBL-AHS solution from ROOTT. So ZBL-AHS solution. Again, in the video that you have seen, what we have done here is we have created an STL file, which a doctor can easily use it to print or mill 24 healing abutments, which are completely compatible with the ZBL abutment. So no doctor has to buy the healing abutments. They can make their own. They can do it with 3D printing. They can do it with milling. They can have the choice of material. They can use biocompatible 3D resin. They can use PEEK, and even some doctors who want to do it like really with the top optimal care, they can use their cornea. Also, the options are like there are 24 options you can choose from anteriors, from center to offset, for premolars, for upper molars, and for lower molars. So this is a solution that we are offering free of charge to our customers at Root, which is like a package. We have the implant with the zero bone loss abutment, and we have the solution so that they can create the ideal anatomic profiles for their patients to achieve higher aesthetics, and it will not cost you anything. So if you check, the total cost of printing for 24 healing abutment will be the same cost of one single healing abutment that you buy. So we make it really precise, really accessible for all of you. Also, in this, you can see that there are different sizes which are available. So each healing abutment option is coming in three sizes, which is small, medium, and large, and it also comes according to how the doctor have placed an implant. If the implant is placed exactly in the center, you can use the centered healing abutment solution. If the doctor is placing an implant a little bit on the palatal side, so you can use it for the offset option. So this will actually help the doctor to achieve the best possible clinical results with minimum inventory and without any dependency for any sales team. Now, for me, if I'm doing a patient and I need something, what do I have to do? I have to call the sales rep and I have to wait till he delivers me. So there is no waiting time because this is available with you as a digital file. If you have an in-office printer, you just need to click and you can get it printed. You can also print a single one. The second most important thing is these files are modified. You can have the single file. If there is any changes you want to do, you can do the changes immediately and you can have a print within 15 minutes. So this is some completely digital workflow. It is optimized. It is extremely cost efficient, and it is also 100% patient centric and compliant with the regulatory. So this is the solution we have, and it has tremendous amount of applications even in terms of using it clinically. So the first and the foremost important thing is to use it in socket sealing. So how we are supposed to use the healing abutment, the ZBL-AHS solution. So we have the implant, which comes with the complementary ZBL abutment. Then this ZBL abutment is directly scannable because it's also a tie base. We have the stock file available for the AHS solution that I already showed you in the video. And this healing abutment solution, you can just fix it and you can screw it inside the patient to develop your emergence profile. I would like to show you some of the cases. Also, as you know, that healing abutment for the ZBL abutment is customized into two different heights for long and short versions, and we will provide you with the files of both long and short versions. So you can use it for the shorter version, which is for the shorter heights, or where you don't want to have any occlusal loading or any occlusal pressure for your ZBL-AHS solution. So you can use it at 4 millimeters or you can use it with 3 millimeters. It's completely based on your clinical wisdom. Then this is just like a sample to show you how you can create easily a temporary crown with the ZBL abutment. It's very easy. It's scannable. You can create it. You can 3D print it or you can mill it. It's all according to you. Have a choice of material to do it. So it's 100% digitally compatible. The files are already available. You can go and download it from the website as ExoCAD libraries or any other system that you're using it. So as I told you, you have 24 anatomic shapes to choose from. You have anteriors, premolars, and molars. You have different sizes available from small, medium, and large. And you have two different offsets. So you have the offset, you also have the offset option, and you also have the height option according to the ZBL. So you have the less, like you have the shorter version of ZBL, which is ZBL 0.4 mm. So you can use it with the shorter one, and you can also use it with the regular ZBL abutment. Now, what is the difference? So here you see an emergence profile which was developed by a conventional healing abutment. As you can see, it's a very rounded profile because all the healing abutments are round. Now, the consequences or the problems with these type of emergence profile in the patient is you always have some dead spaces in the interdental area. But when you use something which is like the zero bone loss abutment and the anatomic healing solution, you can create an emergence profile exactly like your natural teeth. So what we have done here, we have just stimulated the tissue on the sides to create this ideal emergence profile with the help of the ZBL-AHS solution. We have some cases for guided implant. I'll show you how you can achieve the best and the ideal profile. So this was the zero bone loss healing abutment. We have done the planning, fabricated the surgical guide. As you know, like we have three different zones: EBC principle, aesthetic zone, bounded zone, and crystal zone. So in the crystal zone, you will always have the ZBL anodized contact. So it's anodization is always good for the connective tissue because it has a rough surface, minimally rough surface, and then you have the biologic boundary, and then you have the aesthetic conditioning. So this is how it was done. You extract it by sectioning. You have a type A socket. You start the drilling with guided surgery. You place an implant. You have the abutment in place. You already pre-decided the anatomic healing solution, what you have to use, and you place it inside the patient, and that's it. No sutures. Also, this is also providing the socket sealing technique. So the graft doesn't require a membrane. You can actually have optimal pressure from this CBL anatomic healing solution, and it will close all the graft and the socket dead space with it. The result, beautiful emergence profile at the end of 4 months. So you don't need to have an additional 3 weeks or 4 weeks to develop the emergence profile. You will always get it immediately. So this is how it was done. Crown in place. You can see the quality of the soft tissue. And this is the final X-ray. This is the X-ray after 2 years in function. So as you can see, it's one of the most easily applicable modality of treatment that you can pursue. Let me invite Dr. Mustafa. Hello, Dr. Mustafa.
Hi, Dr. Salman.
Hello. Thank you
Can
for
hear me,
joining.
Nice presentation.
Thank you so much. I think I just wanted to give them a brief about how it works, and I'll leave it to you for the more clinical insight.
Yeah, it was very nice introduction. I hope I will go more into clinical. I will show them a couple of cases and going through the zero bone loss concept with immediate post-extraction, one of my very favorite techniques. Now you will allow me to share my presentation, right?
Yeah, sure.
Now you can see my presentation, right?
Yes.
Not yet?
Yes, we can see it. Yes.
Okay.
Perfect. So,
okay.
Thank you for joining, Dr. Mustafa, and I leave it to you from here.
It's my pleasure. Just let me know that you are sure you can hear me very well and the screen is shared, right? Dr. Salman, can you hear me? And the screen
Yeah,
is already
absolutely,
shared?
absolutely. It's loud and clear. Like it's complete. We can see the presentation as well. Please go ahead.
Okay, through the next 30 minutes, we'll go through the treatment protocols for immediate post-extraction regarding the famous classification from the timing, when to do immediate, when early, when delayed, and of course, the triangle or the rule of 5, how to achieve successful immediate post-extraction, what are the criteria, and the debate between to fill or not to fill, how to seal the socket, we don't raise a flap and do advancement anymore, and the value of PET and partial extraction therapy through anteriors, premolars, and eventually molars. So I will start with this short video. This is how we face a clinical scenarios where we have extraction socket. The easiest to start with is a premolar, where we have a elongated socket with a large buccolingual dimension. This is a spider web, which we used to do in the past before the very smart prefabricated custom healing abutments from ROOTT. The custom healing abutment, the value, it seals the socket, it protects the implant, protects the bone graft, and eventually, without doing any effort, you get out with this beautiful, healthy emergence profile that you can scan very easy with a double scanning protocol to deliver a very anatomic, aesthetic crown for your patient. So I always see my patient 3 visits. 1 to do the surgery, extraction, and immediate post-extraction. Then after 2 to 3 months, I remove the custom healing abutment, very easy, and take a scan. And the 3rd visit is to deliver the monolithic zirconia crown on a tie base or on a zero bond loss abutment. So during the next slides, we will go through a step-by-step treatment protocol for this approach. Okay, so this beautiful lady come into your clinic and she has no tooth, extracted tooth, and she come out with a tooth. I think every one of us dreaming of doing this. Am I right? Dr. Salman, you are with me, right?
Yes, Dr. Mustafa, we can hear you. It's a very nice presentation. Like all your pictures are very excellent.
Thank you. So we can face a single tooth in aesthetic zone. We can face a full arch case like this with the same concept. We can apply, we can preserve and maintain the soft tissue profile very easy, thanks to the immediacy and thanks to the custom healing abutment or a temporary crown if you can do. And having this happy, satisfied patient, one more case with the same concept and the same idea. And let's come to the principles. If we go through the chapter of immediacy, what are the requirements of immediacy? We have requirements for immediate post-extraction, which is rule of 5. I'll go through step by step. And of course, immediate loading, which I believe it's like an integral part of this. For the immediate loading, we need a nice design to integrate properly with the ideal bone to implant contact to bring us with the best primary stability and insertion torque, so our patient come out with a tooth at the same day. And for your own knowledge, we need for a single tooth an ISQ records of more than 70% and insertion torque above 30 to 35 newtons, so we can load our patient. And when coming to a principle of when immediate and when early and when late from Daniel Boozer, we have this criteria. So for immediate post-extraction, it means that we will place our implant at the same day. We will do atraumatic extraction and place our implant. But if we are not lucky enough and we don't have, if we have a huge infection, there is no apical stability anchor point, because in immediate post-extraction, we never get our primary stability from the circumferential walls. We always get it from the apical part. And of course, we have a massive research regarding the optimal dimension of implant, the jumping gap, to fill it or not, the combination of soft tissue graft. We will go through every technique from this. But I want you to be aware of that after any extraction, we have unavoidable resorption. Whenever you do extraction, we are losing the periodontal ligament supporting bundle bone, and so we have resorption, and the most problematic is the mid-facial recession. So if we take a look on this case, this patient come to us before doing immediate post-extraction, and I'm showing you here how we minimize with the immediate post-extraction any remodeling that we have. In the literature, we have an average of, after extraction, 2 millimeter in vertical resorption and about 4 millimeter resorption, which is too much. But here, as you can see, we are minimized it to 0.4 and 0.6. So this is very impressive regarding maintenance. It's much easier for your patient and even for us, by the way, because when you are doing everything in one step, you save a lot of time and a lot of money for yourself and for a patient. So when the patient come, we took a scan to measure the volume. How would we start? We placed our implant, we filled the gap, and the most important is the custom healing abutment fabrication. I think Dr. Salman have seen you the prefabricated. It takes much less time during chairside, but with a spider web, it was nice when we are using this in the past by sealing the socket. And we left the patient for 3 months of undisrupted healing. Then we can easily remove it after 3 months to find a beautiful, healed, customized emergence profile to this specific tooth. And thanks for the cold welding, I cannot remove the custom healing abutment without the retrieval. And as you can see inside a 3 months timeline, when you are using a xenograft, we have this popcorn effect. If it is not stable, you can collect it with your tweezer to prevent any infection. Now it's time to do scanning, double scanning protocol, and deliver your crown. So the zero bone loss concept school and the consensus regarding the immediate post-extraction, it comes out with a conclusion of immediate implant placement, we have the patient satisfaction, we are preserving time, and eventually we have comparable results. So we will go through this rule of 5 approach, starting from the 3-dimensional implant placement. And when it comes to aesthetic zone, it's very important to make sure that your implant in the ideal 3D position. And guided surgery is not luxury in aesthetic zone, because nowadays, most of the failure and complication are not coming from osseointegration, it comes from improperly placed implant position. Number 2 is a diagnosis, to be aware, do we have an intact labial bladed bone or not? Because as I said earlier, the main complication with immediate post-extraction is mid-facial recession and aesthetics. And here, one of the techniques you can see, I will talk about it later on, which is socket shield. If you are doing a socket shield or not, the gap matters. It's important to leave a gap. I will not go through to fill or not to fill, but the most important is that your implant should keep a gap at least 2 to 3 millimeters away from the labial bladed bone if it is intact, and maybe more if it is lost. And as I told before, the implant design is very crucial to integrate and get you the primary stability, and eventually soft tissue biotype is very important. So, Dr. Salman and dear audience, I will go through different protocols. Type 1, how to manage it, type 2, and eventually type 3. Are we okay, Dr. Salman?
Yeah, absolutely. Please go ahead, Dr. Mustafa. It's a very interesting topic because every doctor wants to practice and master the immediate implants.
So to summarize, we need to know the rule of 5, which is intact labial bladed bone, very important. We have a good thickness of soft tissue, which means 2 millimeters, and we can measure it from the preoperative CBCT. And we need this apical bone to engage to get a good primary stability. And remember, it's very important to keep a gap between the labial plate and your implant. Never ever place your implant to touching the labial plate of bone. So this is a clinical case. A mother of a friend of mine come to me with trauma to the two centrals, and as you can see, we have one with a horizontal fracture, and this is one of the criteria of hopeless tooth or hopeless teeth. We cannot restore it anymore. So we started after proper anesthesia to do a traumatic extraction. One of the valuable tricks to use a large H file, number 80, to engage the root and come out without using any forceps, without using causing any trauma to the soft tissue and bone in the labial aspect. And the most important is the palatally biased implant positioning. And as you can see here, if you take a look on the upper left photo, when I take a look now, my implant is an apical. The apex of the implant is palatal, but the platform is buccal. So this is not recommended. So that's why I'm recommending you to use a surgical guide, or at least use a floss or elastic here. So I need your implant platform to be at least 1 to 2 millimeters away from this line, because we will see a complication later on in this case. And after placing our implant, we fill the gap with bovine bone, and we use the patient's own tooth to do temporization. And the patient was very happy, by the way, but here we have a very deep bite in the back, which is very risky. So one of the criteria to select during immediate loading, patients with deep bite or no posterior stoppers are very risky. That's why the tooth, as you can see, is a little bit labial version with 1 millimeter recession if you compare it to the contralateral. I will show you how we manage it later on. And 3 months later, when the patient come back, I did nothing, but we have a very beautiful emergence profile from the facial and occlusal photos, as you can see. What we need to do now is to do a double scanning protocol, scanning for the emergence profile, which dictates the sealing zone and the subcritical contour. As you can see, very beautifully healed, stable, soft tissue. But as you can see, the scan body is coming out from the facial surface, which normally cannot allow us to do screw retain. But thanks for the library from ROOTT, we have an option we call the dynamic screw channel or dynamic screwdriver, where we can do switching or inversion for the tie base. As you can see here, the tie base short part is toward the palatal instead of the facial surface. And we are lucky that we can do a dynamic screw channel to switch the screw channel from being facial to being palatal. And this is how it looks like. And when we talk about success, it's not about immediate post-operative, but it's about long-term stability. This is how the patient looks like in 2025. After about 7 to 8 years, everything is stable, soft tissue, and even bone level. Going to more, since I know that placing an implant is not a matter of muscles, how you place your implant engaging the bony walls as any mechanic. No, we need the ideal 3D position, and one of these methods, of course, is guided surgery. With the Twinges software, in collaboration with ROOTT, we have a very valuable to guide our handpiece. So you have the advantage of using whatever the drilling kit you want. We are guiding our handpiece to place our implant in the ideal 3D position with a copious irrigation. We don't have a problem with irrigation anymore, as with conventional guides, and placing our implant as usual with a good primary stability, filling the gap, custom healing abutment. And this is very important. I need always to use a long implants and immediate post extraction to engage a good anchor point for primary stability. And this is a conversion of a very, very thin labial plate of bone pre-operative and how we thicken the labial plate of bone post-operative. And this is how it looks like after 3 months, where we deliver the crown very easy. Going to a type 2 socket where we have no labial plate of bone. So guys, how to diagnose this? Sometimes we can diagnose it pre-operative from the CBCT, or sometimes after extraction, when we extract the labial plate of bone, we fracture it during extraction. And now we have 3 proposed treatment options. Ice cream cone technique from Dentster now, VST technique from Al-Askari group, and connective tissue wall from Giovanni Zucchelli. I will go more chronological from history, going back to 2007 from Dennis Turnau and Smith. They primarily invented this technique mainly for socket preservation by replacing a membrane. And when we are using a membrane in literature, the membrane is more or less having two values. The first one is exclusion of fibroblasts or soft tissue fibers, and we need to give a chance for the osteocytes and bone-forming cells. The second function is to convert a non-contained defect into a contained defect. So if you take a look here on this case, we are not sure that if we have a labial bit of bone or not. And as you can see, we have combined crown root fracture. After extraction, please introduce your osteotomy probe while your index finger is on the facial surface. And if you feel this osteotomy probe, you are lacking the labial bit of bone. We don't have a labial bit of bone. After that, we did the normal things by doing palatary bias osteotomy preparation. And as you can see on the right-hand side, the osteotomy and the socket. And this is a precious triangle between where we get the primary stability from. This is very important to preserve this piece of bone. Palatary biased. And here is the cone or the membrane where we used to exclude the fibroblast, placing the bone graft, allograft, cortical cancellous in between. And then we use the patient own tooth to do temporization. And this is the socket conversion. How we converted the very thin labial bit of bone in 2 to 3 millimeter buccal thickness. And this is how we looks with a temporary and with a final crown. And after 8 years, we have a very stable results. Going to a second option, which is connective tissue wall. If you are a periodontist, if you are mastering soft tissue, maybe doing a soft tissue graft, I believe in soft tissue graft will increase and mature with time. If you compare soft tissue and bone shrink with time, bone resorb with time, but soft tissue mature and thicken with time. So one of the good options is to do a soft tissue graft simultaneously with implant placement and socket grafting. And this is how it looks like. So here we're merging two techniques, the soft tissue grafting and socket grafting together with root submergence or root banking. And it's a very nice technique, which I will cover later on when we talk about socket shield. One more case, we have a very thin labial bit of bone and very thin soft tissue. So one of the precaution of the prevention we can do is to do a soft tissue graft simultaneously by doing a pouch or a tunnel, placing our soft tissue graft. I prefer nowadays to do a instead of subepithelial connective tissue graft to do deepithelialized with a more lamina propria and more thickness. Jumping gap filling with bone. And as usual, since we have a good primary stability, doing a temporization, whatever the methods. And here we did a double crossed matrix suture to gain or do overcorrection for the gingival margin. And eventually, here's the conversion, how the bone from very thin labial bit of bone, how it turns with a very stable labial bit and soft tissue. Now with our fourth technique, which is socket shield. So socket shield done or started with the two brothers. They are not brothers, the two identical twins, Marcus Herzler and Otto Dur from German group, then completed with Howard Gluckman from South Africa. So if we apply this, I will go forward. The socket shield and pontic shield and root submergence, all of them belong to a family of PET, which is partial extraction therapy. With partial extraction therapy, we are intentionally leaving the root or a part of a root to deceive the body biology. And this is the only technique I believe that absolutely leading to no bone resorption at all. When we are talking about dual zone concept or ice cream cone or a soft tissue, we are trying to compensate for the expected loss. But here we are absolutely losing nothing. So here we will keeping the labial ablative bone. As you can see, we have a very thin labial ablative bone and very thin soft tissue. We started as if we are doing a root canal treatment or a post and core by doing a preparation with a low speed burrs, gates or endophiles as you want. Then after taking the tactile sensation of the root, we are doing sectioning with a long shank burrs and doing thinning. I need my socket shield to be 1 millimeter thickness. We don't need more. We don't need the thickness of the root. We need the periodontal ligament which is attached to the root. Make sure that you understand this, okay? So I need it to be very thin. As you can see here, this is too thick. And I need it to end up at the line angles. We don't need more. And I need it apicocoronal to be with the level of the bone. We don't need it to be higher because it may increase the risk of shield exposure in the next time. Then placing our implant in the ideal 3D position. And this is the beautiful soft tissue we get. I never see this pointed papilla without doing a kind of PET or a partial extraction therapy. And not only this, 10 years follow-up, we still have a beautiful, stable results. And here a video for you to understand how the socket shield go through one more clinical case. Here is a lateral incisor we prepare with a Gates or Gates Glidden. You can use it without irrigation, no problem. I need you to see. And for the socket shield, I recommend you all, you must work with a magnification. You cannot do it with your naked eyes. Then we work with a long shank burr, as you can see, cutting only from the apical 3 to 5 millimeter, doing proper dryness so you can see properly where you are. After that, the more we are getting apical, the more we are sticking to the long axis of the root to avoid any injury to the adjacent roots and bone. After making sure that you have a concomitant sectioning, start doing luxation, but never between the two roots. Luxation should be at the palatal part, because if you did a luxation in between, you will move both shields. If you feel it moves, go ahead. If it is very stable, please do more accentuation for your cutting lines. Removing our shield very easy with the forceps and rotation movement, as you can see, very cleanly cut with the apical part. Even you can see the cataperca. Now it's time to trimming and finishing for the shield by keeping it 1 millimeter thickness, ending up at the line angles and below the gingival margin 2 to 3 millimeter or at the same level of bone. Then, as usual, immediate post-extraction, do dryness to check that the socket is absolutely clean, no granulation tissues, no inflammatory tissues at the apex. This is how we can do apicocoronal trimming and finishing for the shield. And then starting doing apical and palatal osteotomy preparation, taking x-rays very crucial, or as I told you before, guided surgery, maybe a replacement. I always, in this kind of cases, use long implants. Here I use 3.0, the ideal for me for the lateral incisors with 16 millimeter length, getting a very nice primary stability so I can load my implant. Here is the insertion torque, as you can see, and the apicocoronal, I need my implant platform to be 4 to 5 millimeter apical to the gingival margin or the correct dentist point. And custom healing abutment, as you can see, very nicely prefabricated. We can do a socket sealing, and eventually, if you need to do some trimming, no problem, and filling the gap. And this is the first visit. The nice thing, when the patient come back, remove it, and you have a very nice emergence profile. All you need to do a double scanning protocol by scanning emergence profile and scanning, and deliver the crown for your lovely patient with a lovely smile. So sectioning, one more case, trimming, placing your implant, and when the patient come back, you see this beautiful after 7 years follow-up. Very stable buccal profile, very stable soft tissue thickness. What do you think, Dr. Salman, about socket shield?
Well, this is an amazing treatment modality, but it is highly technique sensitive. So I think you need a mentor to first do your cases together, because
That's
it
why
seems to
in our
be
next master class in next April, in collaboration with ROOTT, we are aiming to bring doctors from all over the world to visit the lovely Egypt, have some tourism, and have some couple of cases, clinical training on patients, doing a socket shield, doing a soft tissue grafting with immediate post-extraction in aesthetic zone, doing the ice cream, and even the VST, all the treatment modalities, because this kind of treatment is very common in daily practice. So we need the clinician to master this kind of treatment. I will show you one more case and the value of guided surgery. If you take a look here, we have a very, very thin labial dated bone. And we have more. As you can see, we have ankylosed root, but here we couldn't do only socket shield because the shield or the root is fractured 2-3 millimeter below the gingival margin. So as you can see, when we remove the fractured crown, the soft tissue is not supported anymore. So in this kind of case, we will combine both socket shield together with soft tissue grafting. So it's not, let's say it's a case-by-case decision. We cannot apply every single technique to all the cases. We need to have a mind mapping and have a very nice decision tree in our mind so we can apply it for different clinical scenarios. And here we did a guided osteotomy preparation. Checking with X-ray to make sure that the guide is going in the right way. Placing our implant with a good primary stability. And even we have a prefabricated crown. And now we need to do, as you can see, when we place a prefabricated crown, we need to support this with a soft tissue. We will do pouching. This is one of my favorite techniques. I always trying to teach it to my students because it solves a lot of problems in the primary scenario, or sometimes when you do your implant not in the ideal, let's say nothing goes in the ideal way, soft tissue always save your back. So soft tissue grafting is one of the very important techniques which I teach in our clinical or our next master class in April 3rd and 4th, inshallah, in Egypt, Cairo. So here is the soft tissue pouched in, supporting, positioning and fixation suture. And as you can see, we just need to fill the gap with bone. And this is the steps, soft tissue inside. This is how the soft tissue become pregnant after doing the soft tissue graft. And of course, the temporization, the provisional is very important to support our soft tissue. And when the patient come back after 3 months, doing the final prosthetics, and we have a very identical pink and white aesthetics. Let's raise the bar and do it guided, not only the implant placement, but also the sectioning of the shield. So here, as you can see, we have a failed restoration in the canine doing sectioning guided. I will show you how with a short video. Let's see. All these videos are on my YouTube channel and on the Facebook and Instagram. You can revise it anytime. I love if we have more time to be more slow. Sorry if I'm a little bit fast, but I'm trying to give you all the tips in this short time. So here is the first guide, which we use to guide us to reach the ideal long axis of the tooth and root canal. After that, we can safely section the root without doing any buccal perforation, any interproximal perforation, and safely extract the palatal part. Then after sectioning, we need to do some trimming for the shield, as I told you before. And we have a very nice palatal bone where we get the engagement with a surgical guide. So osteotomy preparation with a guide, and the shield preparation is also with a guide. And we have a prefabricated crown. So we planned everything before even starting the surgery. Here is a prefabricated crown on a tie base. We did pickup. It's one of the easiest methods. If you are fully guided, you don't need even to do pickup. The crown is already ready at the last case. And as you can see, the patient come in with no tooth, come out with a tooth. And not only this, with a follow-up, one of the complications, because I always love to teach you complication. Complications teach a lot, not only showing you the nice cases. As you can see here, one of the complications is internal shield exposure. If we go back to the photos, and you can see that the shield is too thick, that's why I told you I need the shield to be 1 millimeter, 1.5 is more than enough. We don't need more. That's why we have this shield. And how to manage this kind of complication? Just to do reduction of the shield, but make sure it's not mobile. And this is how it looks like after 1 week from the shield reduction. The soft tissue heals over the shield with no problem, and we can deliver our crown with no complication. Come out to our last treatment scenario. So we agreed to summarize that everyone is understanding to do an immediate post-extraction. We need an intact labial bladed bone. We need an apical bone to get the primary stability. And we need to always leave a jumping gap, which we're gonna be filled with allograft cortical cancellous. Sometimes if you have a thin soft tissue, we can implement soft tissue grafting. But what if we are absolutely lacking the labial bladed bone? Maybe we can go with Boozer technique to do extraction and only wait for 6 to 8 months where we're gonna do a GBR as proposed by Boozer. But this take a lot of time and have the disadvantage of doing vertical incision with expected scars and a lot of waiting time. So one of these techniques proposed by the Egyptian Alexandria group, Al-Askari and Mu'taz, the VST. I will show you a short video for this. Very interesting. If you're absolutely lacking the labial bladed bone and we have a large lesion apical, one of the options is to do a socket conversion by doing a VST, vestibular socket therapy, by instead of doing a vertical incision and circular incisions, we are keeping the most precious part, which is the gingival margin and papilla, and we will go a far apical, away from the smile line, away from the aesthetics, and do a small horizontal incision at the mucosa. It should be at the mucosa level, and do a retrograde tunnel or a pouch, as you can see. Through this tunnel, we can clean the socket. We can making sure that there is no inflammatory tissues. If we have sequestrated bone, as you can see, we can remove it. And we will introduce a novel membrane from osteobiole. It's a bone membrane where we can restore the lost labial bit of bone with a bone instead of using a membrane as ice cream cone. And through this incision, you can see the guidance to make sure that the implant is in the ideal position, as you can see here. Placing the implant with the osteotomy preparation with the surgical guide. Placing our root implant as usual in lateral incisor 3.0 by 14 or 16 is my usual choice. And now we need to restore the lost labial bit of bone. As you can see, I love the cold welding. Placing our implant to be 4 to 5 millimeters from the venous point, and doing the patron for the membrane or the bone lamina, which we're gonna support with 2 screws or 2 tacks apically. And from the coronal part, it will be just tucked in below the gingival margin. And eventually, we can close this through a small 6-0 Prolene or nylon sutures. And this is how it looks like. This is some of the cases which we already solved it with the beautiful novel technique, VST. This is the case. You just have seen its video. The pouch again. If the video is too fast, we can revise the photos together. Osteotomy preparation, guided implant placement, and bone lamina in place. So if you can see from the photo, it's not a membrane, it's not a collagen, it's a bone lamina. And eventually close everything with sutures, temporization. And as you can see, the socket conversion, how we have a thick bone. When the patient comes after only 3 months, we can start our prosthetic way. But one of the drawbacks, of course, is this scar. I'm a very honest guy. I'm showing you all the pros and cons of every technique. So make sure that your incision is too apical. If your patient have a gummy smile, it's not a treatment of choice. In this case, we have a very nice soft tissue profile, as you can see, and stable pink and white aesthetics. So let's come to a conclusion, guys. If you have an intact soft tissue and bone, before and after extraction, just place your implant in the ideal 3D position and do dual zone grafting by grafting the socket not only to the bone level but also to the soft tissue to do a soft tissue thickening. If you have an intact labial blade of bone but you have a thin soft tissue, do either a soft tissue graft or a socket shield. So if you are a with a periodontist background like me, I prefer soft tissue. If you are endodontist, you can prefer socket shield. But if you are type 2 here, if you are lacking the labial bit of bone, either pre-operative or after extraction, we have to restore the labial bit of bone by doing ice cream cone or doing a VST. If we are absolutely lacking the labial bit and soft tissue, it's a type 3 socket. It's recommended not to do, just extract and wait. And maybe after 6 to 8, we need to build the bone. So a take-home message, maintenance is much more easier than creation. So for me, doing immediacy is 95%. I'm trying my best to do immediate post-extraction. Guided surgery and precise data collection and planning will make your life easier. And primary stability is very crucial for immediate loading. And immediate loading not only satisfying patient, but also satisfying us by preserving everything and sealing our sockets. Immediate temporization with a custom healing abutment is really game changer. And eventually, of course, intraoral scanners nowadays is a standard of care. Thank you guys for attention. And if you have any question, I'm here.
Thank you so much, Dr. Mustafa. Thank you for this lovely insight on the implants, especially the aesthetic modalities. And I'm really thankful that you possibly compiled this beautiful presentation of all possible treatment options that the doctors can offer for immediate implant placement and provisionalization. So we have a couple of questions I would like to ask you. It is coming. So
Yes, please. Just give me a moment before answering the question, guys. This is a QR code. You can scan it. Through the QR code, you can find this presentation. So if you miss anything, you can go back to the presentation. And also you can find the website where you can find the videos and the YouTube channel for all the videos on my presentation and much more videos. Thank you, guys.
That's really generous of you, Dr. Mustafa, to give such lovely presentation and accessible for everyone. And also the YouTube videos, I think everyone will go there and definitely look in detail about all the techniques. So the first question that we have is about the thickness of the shield. So I think it's already, like you mentioned it, and you also mentioned the complication. Can you please summarize it about the thickness of the socket shield?
Okay, no problem. Let's go back to, I always love to focus on the biology. Guys, we don't need the thickness of the root. Our root is avascular. The human root or the dental root has no blood supply. We don't need the root itself. We need the periodontal ligaments, which coming out from the root to support the very thin bundle bone. So it's not the matter of thickness of the root. So I need the root to be 1 to 1.5. If it is less than 1, we have a possibility of displacement or mobility. If it is too thick, you are creating more avascular space, which it's better to be filled with blood clot. I hope my answer is clear.
Perfect. Thank you so much, Dr. Mustafa.
So 1 millimeter thickness is more than enough. Regarding the let's say the extensions, the mesiodistal extension, I needed to stop at the line angles only to support the papilla. Regarding the apicocoronal, we needed to be just flushing with the labial bladed bone if we are type 1 socket, by the way. Because socket shield, sometimes we can do it if we are type 2, if the labial bladed bone is lost. But in type 2A, which means we are only lacking the coronal part of the bone, not the middle and not the apical. Because if we are lacking absolutely the labial bladed bone, the shield will be mobile.
Thank you so much for the insight. One more question we have, it's about the choice of grafting material. What is the ideal choice that you use for this?
Going back to biology, the most important is the blood clot. So we need, if I want to give you like an advice, the most important is never ever place an implant in aesthetic zone more than 3.5, 3.7. The more you are increasing the diameter of the implant and reducing the gap, the more you will get collapse, because the titanium is not have a blood supply. So we need a blood clot. If you have a blood clot, let's go back to your question. What the ideal criteria of bone graft? The ideal criteria of bone graft is to be remodeling with the same rate of new bone formation. So if we take an example, the autogenous bone is a gold standard, right? But the autogenous bone will resorb fast. So if the autogenous bone resorb fast, we will get collapse. On the other hand, if you are using a xenograft, it will give you a very nice stability of the soft tissue and bone. But the problem is, if your connective tissue is distorted for any reason, you don't have bone beneath. It's only biomaterial. So to cut the story, the very long story short, we need the cortical cancellous allograft because they have the modest criteria by being replaceable and at the same time or the same rate of new bone formation.
Thank you so much, Dr. Mustafa. It was really, because most of the doctors are confused of what choice of graft to use where. So I think the ideal one that you answered is the cortical cancellous. And actually the best thing is the way you answer it. It's completely with the reason with biology. So this is
because I have been there.
I really love your explanation. To be honest.
Questions in my mind and nobody answered it. That's why I'm trying to make it easy.
Also about the when do you prefer to add a soft tissue graft? So is there any criteria for this?
if I have a thin gingival bitype, let's say, first of all, if my patient is demanding patient, let's say a young, beautiful lady with high smile line, we need everything to be perfect. So if I have a thin gingival bitype, which is less than 2 millimeter, which, as I said, we can diagnose it from the CBCT pre-operatively, right? Measure with your
Yep.
cursor how it is. If you have a soft tissue less than 2 millimeter, I recommend you to do soft tissue graft. Tuberosity is a very nice option for a single tooth. It's not painful for the patient. It's very easy to harvest. Is it clear? Hello?
Yes, Dr. Mustafa. Now we can hear you. I think you were cut off. Hello?
Should I repeat the answer again?
Yeah, we were there till the lady with high smile line
Yeah,
and high aesthetic one.
okay, if we have a soft tissue thickness less than 2 millimeter, which can be diagnosed from the preoperative CBCT, I'm recommending you to do a soft tissue graft.
Okay. So this is amazing. So again, thank you so much. I think we're already half an hour above the time. So again, I would like to invite every one of the viewers to please enroll for the masterclass for Dr. Mustafa, which will be happening on the 4th and 5th of April in Cairo, Egypt, with an amazing session with him one-to-one. So you will be able to see and assist and practice all the techniques which Dr. Mustafa mentioned for soft tissue enhancement to immediate extraction and immediate loading, and what are the protocols, which is most important. You will also have an idea about how successfully you can do the socket seal technique and what are the criterias to select which technique in the optimal case. So thank you so much, Dr. Mustafa.
Thank
I'm
you,
really
Dr. Salman.
happy for the insight that you give in this session, and we are looking forward for more insightful sessions with you.
It's my pleasure. Thank you, and thanks for the attention from the audience.
Thank you so much. Take care. Bye-bye.
Bye-bye. Bye-bye. See you.